Hello everyone, it's 12 o'clock, so it's time to start the HTMR webinar for today. Thank you all for coming along. We're going to hear from Charlotte Scomparin today from the University of Warwick, and she's going to be talking about the Paramedic 2 trial. This is a really interesting webinar which follows on from the one that some of you might have heard previously, Addie Perkins, from earlier in the year. And if you'd like, it might be nice to go back and listen to the two of them side by side. Charlotte has a background in clinical research. She has an MSc from Cranfield University. She's currently based at the University of Warwick Clinical Trials Unit, and she's been working in an interesting area of research for the last 7 years. So she was first in the initial Paramedic trial, which involved evaluation of a mechanical chest compression device for in and out of hospital cardiac arrest. So there's lots that's interesting there. And she also set up the UK out-of-hospital cardiac arrest registry. For the last 4 years, she's been the trial manager on Paramedic 2. So it'd be really interesting to hear about her experiences with that. Just before we start, could I ask that anyone that still has their their microphones and switched on for the duration of Charlotte's talk, could you switch it off, please, because we may be able to hear. And then if you would like to speak later on, you could switch your microphone back on. So Charlotte, if you're ready, I'll pass over to you now, and then we can come back for questions later on.
Okay, thanks Claire, and hi everyone. Thank you so much for listening in, and I really hope that you find it an interesting and useful discussion. So I'm going to be speaking about conducting a pre-hospital emergency care trial, which brings quite a few challenges with it, and speak about how we tackled some of those challenges on the Paramedic 2 trial. So just a couple of disclaimers here. The trial was funded by the National Institute for Health Research HTA programme, and the views expressed are not necessarily those of the NHS, NIHR or the Department of Health. And these are the various aspects of the trial that I'm going to be speaking about. So ethics, communication and media, randomization, data collection, consent and training. So I'll jump straight in and give you a brief overview of the design of the Paramedic 2 trial. So the trial has been running since 2014, and it's a pre-hospital, double-blind, randomized control trial investigating adrenaline versus placebo as a treatment for out-of-hospital cardiac arrest. The trial involved over 8,000 patients and operated in 5 different NHS ambulance services in the UK. And the rationale for doing the trial is that adrenaline's been used now as a treatment for over 50 years, but has never been properly tested to see if it's safe and effective as a treatment for cardiac arrest. So recent observational studies have actually suggested that it may be doing more harm than good and may not improve long-term survival and may be associated with worse brain damage in patients that do survive. To give a bit more context, cardiac arrest is the most life-threatening medical emergency, and it occurs when the heart actually stops beating. So it's different to a heart attack, which is where the heart is damaged and continues to beat. Within seconds of a cardiac arrest occurring, the circulation of blood to the brain and the other vital organs will stop, and the patient will become unconscious and unresponsive. So as you can imagine, as a research environment, this is extremely challenging. So what specific challenges does this present? Well, firstly, because the patient's unconscious, it's obviously not possible to get informed consent from the patient before recruiting them into the trial. The occurrence of a cardiac arrest is unpredictable. Often there are no warning signs and it can happen anywhere. So there might not be a bystander or a relative there who could provide consent on behalf of the patient. If there was someone present, it's obviously an incredibly distressing and emotional situation to witness. So we could argue that that person might not have capacity at the time to make any informed decision about research participation. And the fact that a cardiac arrest is an unpredictable medical event also means it would be really difficult to target specific individuals that would be likely to suffer a cardiac arrest in order to get prospective consent or dissent in advance of a trial happening. So all these things really pose an ethical challenge. On top of that, the treatment for cardiac arrest is extremely time critical. And we know from research that for every minute of delay in starting treatment for a cardiac arrest, the chances of survival reduce by 10%. So clearly, paramedics' immediate focus needs to be on delivering life-saving treatment, and taking time to discuss things such as consent would result in harm to the patient. It also means that any trial procedures such as assessing eligibility, randomization, and delivering the intervention must be done extremely rapidly so that there's no delay in treatment as a result of the trial. A further challenge is that a recovery from cardiac arrest can vary a great deal. Some patients make a really good recovery and they're discharged from hospital within a few days. So that means any kind of deferred consent or follow-up from the patient needs to happen quite quickly. Conversely, patients may sustain significant neurological damage and may never regain capacity to be able to consent following a cardiac arrest. So that means we need to get deferred consent from a legal representative instead. And the sad reality is that in this population of patients that we're studying, less than 5% survive to be discharged from hospital. So that raises further ethical and logistical issues about how we can collect data on these patients, and also whether relatives of deceased patients should be informed about the trial. And finally, for most paramedics, a cardiac arrest is actually a relatively rare event to encounter, and a single paramedic may attend on average only one cardiac arrest in a year. And that means large numbers of paramedics need to be trained to deliver the trial intervention in order to recruit sufficient numbers of patients. And we need to think about how we can keep that training fresh in their minds. So despite the challenges of doing research in this setting, we must remember that there's an ethical obligation to provide patients with the most effective evidence-based treatments in order to improve outcomes for patients. So we need to find ways of conducting research in these difficult settings. For Paramedic 2, we had patient and public involvement throughout the trial and began PPI work even during the design stage. So we sought the views of patients and members of the public, as well as doctors, nurses, and paramedics. And in a community survey, 86% agreed that the trial was needed, and 75% said they would be willing to participate in the trial. When they were asked about which cardiac arrest outcomes were most important, 95% of survey respondents felt that long-term survival without brain damage was most important, which further supported the design and the rationale for doing the Paramedic 2 trial. So in terms of the consent model that we used, we sought approval for a waiver of consent from the Research Ethics Committee. And that's in line with the UK Clinical Trial Regulations 2004 and the 2006 Amendment. And that allows patients to be recruited without informed consent in emergency situations. Now, one of the conditions of using a waiver of consent is that the patient or their legal representative must be informed about their involvement in the trial as soon as possible once the initial emergency is passed. And they must be asked for consent to continue in the study. So for Paramedic 2, we discussed this with our PPI representatives and asked them when would be the most appropriate time to speak to patients following a cardiac arrest. And the decision was made to approach patients only once they've reached the hospital ward. But this brings up another question of whether relatives of those that don't survive should be informed about the trial. And after careful consideration and consultation with patients, members of the public, and the Research Ethics Committee, it was decided that the potential burden and distress that would be caused by contacting the relatives of deceased patients would outweigh any potential benefit. So instead, we sought to provide information about the trial in various public settings so that relatives could seek out more information if they wished. And I'm going to cover how we did that in more detail in a moment. We also provided a mechanism for a person to indicate in advance that they wouldn't want to participate in the trial should they have a cardiac arrest. And they did this by requesting a metal bracelet, a bit like a medical alert bracelet, which could be worn during the trial recruitment period. And the paramedics were trained to look for these bracelets if they attended a patient in cardiac arrest. And this is a system which has already been used successfully in several North American resuscitation trials. But as an additional measure, the ambulance services could also add a flag to that patient's home address on their dispatch system. And we also encourage those requesting bracelets to discuss their preferences with friends and family to make them aware of what their decision would be regarding participation. And these are the leaflets and posters that we designed about the trial to be displayed in various community settings, such as GP surgeries and pharmacies, and really anywhere where potential patients and relatives would be likely to visit. So we had a lot of PPI input into the design of these posters and leaflets in terms of the content and how easy they were to understand and how we could best distribute them. In total, we sent out around 66,000 leaflets and 7,000 posters, and that's not counting any that were sent electronically. We also designed a comprehensive trial website, which has been accessed over 175,000 times since the start of the trial. And the website includes various information about cardiac arrest and the rationale for the trial, some frequently asked questions, and there's also a form on there for requesting the metal bracelet or to find out whether a relative was enrolled in the trial. And before recruitment to the trial started, there was various media coverage about the trial as well, in terms of radio, newspapers and television interviews. And the photos here show one of our clinical investigators, Jerry Nolan, being interviewed on BBC Newsnight, and Helen Pocock, who's one of the lead research paramedics in South Central Ambulance Service, doing a piece for ITV News. Unfortunately, as you can see from some of the headlines, they weren't always accurate or helpful, and sometimes carried sensationalist headlines talking about heart attacks rather than cardiac arrest. So I think it's fair to say that some of the headlines caused a degree of public concern at the start of the trial. And this is just a graph showing the number of requests that we had for the metal bracelets during each month of the trial. And in total, we issued 1,157 bracelets. As you can see, the majority of those requests came in January and February of 2015, which coincided with when some of the more negative headlines were published. So I'm going to move away now from some of the ethical challenges to talk about some of the logistical issues. So I mentioned earlier that treatment is absolutely time critical and any trial procedures mustn't delay treatment of the patient. So that meant that any system of randomization we used had to be practical, and we couldn't use, for example, telephone or computer-based randomization. So we had to find a really instant method of doing that. So in terms of the way we did the randomization, there was a randomization sequence that was generated by the statistician. And that was essentially a list of sequential 5-digit pack numbers that were randomly assigned to be either adrenaline or placebo in a 1-to-1 ratio. And this list of pack numbers was sent to the manufacturer to manufacture identical drug packs, each containing 10 syringes of adrenaline or 10 syringes of saline solution according to the randomization list. and each pack could be identified with this unique 5-digit number. The drug packs themselves were delivered to ambulance services and put onto vehicles, and there was one pack on each vehicle. So when a paramedic attended a cardiac arrest, they would assess whether the patient was eligible and then open the drug pack ready to administer the treatment. And the point at which the pack was opened was deemed to be the point at which the patient was randomized to a particular treatment arm. I'm going to move on to now to talk about data collection. So again, we really needed a simple and quick data collection process, and we needed a way of finding out as soon as possible once the patient had been enrolled into the trial, so that any surviving patients could be followed up in hospital and approached for consent. Learning from our experiences in the first paramedic trial, we knew that a paper-based data collection system just wouldn't be quick enough to allow that to happen. So we had to try and come up with an efficient process using electronic data capture. So this is the process we used. Essentially, after a patient was recruited into the trial, the attending paramedic would phone in or radio their local research team and tell them that they'd enrolled a patient. And they'd provide some basic details about the case, such as the case number and the 5-digit drug pack number that they used and the patient's status. And it was that 5-digit pack number that would then tell the statistician which treatment the patient had received. The research team would then register that patient on an online trial database that was designed by our programming team here at the Clinical Trials Unit. And on most occasions, we'd have the baseline data entered in the database within 24 hours of the cardiac arrest occurring. So follow-up processes would then be initiated, and the rest of the data was also entered via electronic data capture using ambulance service and hospital medical records. Now, I know some people listening in may already use electronic data capture systems, but this was the first time that we were using this system for a trial, as opposed to paper case report forms. So I thought it might be helpful to just share some of the pros and cons based on our experiences in Paramedic 2. In terms of pros, it definitely maximised the speed and the efficiency with which we could collect data. And that was really important on such a big trial, because at the busiest times we were recruiting around 500 patients in a month, so there was a lot of data coming in. Theoretically, it should reduce the risk of transcription errors, simply because there are less transcription steps involved. And it's also possible to validate data contemporaneously or as it's being entered into the database, which should then reduce the number of data queries overall. It's also possible to get a real-time view of the data for interim analyses and DMC review. When you're looking at very short-term outcomes, such as survival, you can have a very up-to-date picture of safety and efficacy, which was helpful in Paramedic 2, as we had very frequent interim analyses. In fact, they took place every 3 months during recruitment. And it's also possible to run data query reports automatically, which again reduces the risk of human error and improves efficiency. In terms of the cons, it might require a bespoke system to be set up and to have all the functionality that you want, and obviously requires programming input both up front and then throughout the trial to develop the system and the reports. It's possible that the end user, so that was our research paramedics in this case, might not have all the functionality that they need within the database to be able to track things like data queries or patient follow-ups. So what we found was that there was some degree of duplication of data entry processes, where they would have maybe a separate spreadsheet for tracking patients. So that's not really ideal. And finally, electronic data capture might also require more training and technical support on hand compared with paper-based methods. I'm going to move on now and talk about consent in hospital and specifically approaching patients after a cardiac arrest to take consent. And this was quite different in that the trial intervention was complete by this point, and this was the first time that they were being informed that they'd been involved in a trial at the time of their cardiac arrest. So it obviously had to be a very sensitive approach. The approach and the consent itself was done by ambulance service research paramedics rather than hospital staff. And to help with making that approach, we had a local collaborator and a day-to-day contact in each hospital across the country that could potentially receive trial patients. So that required a lot of R&D approvals and letters of access to be in place. The research paramedics would then speak to these hospital contacts to find out when would be the most appropriate time to come in and speak to a patient, and also to find out whether they had capacity to consent for themselves. If the patient didn't have capacity, then they would approach a personal or a professional legal representative for consent. And it's important to note here that because the trial intervention was finished at that point, then consent was only taken for future data collection and the completion of follow-up questionnaires. But not only were the research paramedics having to have these difficult conversations with patients or relatives in hospital, we also found that they were faced with language barriers as well. And these were all the languages that we encountered during the consent conversations. So in order to prepare for this, we got translations of the patient information sheet and the consent forms ready-made in the most common languages. And where we didn't have an information sheet available, we used a service called Language Line to be able to have an interpreter on hand. And the final thing I wanted to cover was trial training. So each of the ambulance services that we worked with employs hundreds of paramedics who could potentially attend a cardiac arrest. So we needed to train sort of a critical mass of paramedics in order to recruit 8,000 patients within 3 years. So to do that, we worked with our team of 26 research paramedics. They were trained on the trial protocol, and we gave them a kind of core training slide set, which could then be used to go out and train operational paramedics. They were absolute champions and trained 3,220 operational paramedics on the trial intervention. And they used a variety of different ways of doing this. So they all had slightly different localized processes, so they had to come up with their own local training package. Some sites used an e-learning system and designed a bespoke module within that. And some did face-to-face training, either on an individual or a team basis, or organised full training events. And in some cases, they were able to get the trial training onto the statutory and mandatory training for staff, which was really helpful. And finally, we had a site that produced a training DVD and then held DVD screening events in order to train their staff. And as I mentioned previously, paramedics may only attend one cardiac arrest in a year, which means it could be a long time between completing the trial training and actually recruiting a patient. So we had to think of various ways of keeping that training fresh. And this slide just shows some various examples of reminders and prompts that we implemented during the trial. So we made a pocket-sized aid memoir for paramedics to keep in their uniform, and they received that after they completed the training. There were regular posters on ambulance stations, such as on lockers and in mess rooms. We created a training pack which paramedics could pick up and read while on standby, and there were stickers on ambulance dashboards. We also had a pen that had a rollout kind of aid memoir, and we also placed extra stickers on the drug packs just as another reminder of the eligibility criteria. The research paramedics were also offered refresher training sessions throughout the trial, but I think these reminders and prompts were really essential, not just to remind people not just to remind them about the trial, but also what to do when they actually enrol a patient. Okay, so I'm going to end with a quick summary and some lessons learned. So the only way that we could do the Paramedic 2 trial was with a waiver of consent, and with that came some real ethical challenges. And in trials like this, as well as having ethical approvals in place, I think there needs to be significant PPI consultation even before the trial starts to make sure that the design and the rationale is acceptable, and also to provide the patient perspective when making some of those difficult decisions. In terms of media and our communication strategy, we learned a lot about the importance of getting accurate information into the community settings. And for trial procedures, we had to think about what was practical in this situation in terms of processes such as randomization, and really making the processes as simple and as quick as possible in order to minimize the demand on clinical staff. And this is the first time we were using electronic data capture instead of paper CRFs, and found it to be a much more efficient process in terms of collecting and processing data quickly. So this is definitely something we'll be using for future trials. For consent after the emergency has passed, we had to consider how best to make that approach in such a sensitive situation. And again, using PPI involvement as well as relationships with hospital staff to determine when's the most appropriate time to make that approach. And really preparation was key here, and thinking ahead about potential questions and things like potential language barriers. And finally, I think in order to train so many paramedics, it was important to make that training as accessible as possible. And I would say don't underestimate the importance of training aids and reminders, even if the eligibility criteria and the procedures are really simple. In emergency situations, you really need to have a fail-safe system in order to reduce the likelihood of human error and really minimize that demand on paramedics. Okay, I'd just like to end by acknowledging all the various people that have been involved in the Paramedic 2 trial. There are too many to name individually on one slide, so these are the various groups that have been involved. And just to say as well that the results of the trial have now been published in the New England Journal, if anyone's interested in having a read. And I've just got some contact details up there on the screen in case anyone had any further questions after the webinar. So thank you so much for listening, everyone, and happy to answer any questions.
Lovely. Thank you very much, Charlotte. And that slide you had just a few back, there's so many questions that could come out of all of those things that you highlighted. It's really, really interesting. If I can start maybe while other people are thinking of their questions, and if anybody would like to put a question to Charlotte, you can either write it in the chat box and we'll go over that, or if you've got a microphone, you'll be able to unmute yourself and put the question to Charlotte yourself and maybe discuss it if you let us know in the chat box that you'd like to do that. But I'd quite like to go back to some of the things on that slide. One of the most recent things you talked about was the training, and that was clearly a really big undertaking. Did you get a feel that any one of those three different approaches was more effective than the other?
I don't know that we had a really objective measure of which one was most effective. I'm sure the research paramedics who delivered the training would have a better feel for this. But just, I guess, thinking about the different methods, the majority of paramedics were trained via face-to-face training. And I think that's got various advantages in that it's easier for people to ask questions, and they're more interactive, so they can check their understanding of trial procedures. And there's potentially more buy-in, I guess, if there are large sessions that are being run and you can see colleagues all getting involved in the trial. And we have to remember that this is something that paramedics were doing, they were doing training in their overtime and on top of their normal clinical jobs.
Okay.
In terms of the DVD and the e-learning, I think that had several advantages in that it was obviously convenient for people to do, and they could go back and revisit the training, and it was good in a sense that you put in the work up front to produce the DVD and the e-learning, and you can potentially train very large numbers without having necessarily spending a lot more time in delivering those training sessions. But I guess the downside of those is they're not quite as interactive, and it may be, if there's any changes in the trial processes, then it might be more difficult to make amendments to things like a DVD or an e-learning package.
Yes,
so one service, sorry Claire, one service did quite a nice combination of the two. So they held screening sessions to show everyone the DVD, and then they were also available if anyone had any questions.
Great, thank you. The questions are starting to tumble in, and I can see that some of them are on particular themes. So we'll try and group those. There's a few people asking about the consent process, but unfortunately we have people listed as guests and numbers rather than people. So I'm sorry we can't acknowledge you. If we go to the first one that was up, and then I might start trying to group some of them. You were asked, the very first one was about GDPR and whether you think that might affect the ability of researchers to use the opt-out approach to dissent, having to have that information.
That's a good question.
It is, isn't it?
As far as I'm aware, I don't think GDPR has had any impact on the regulations in terms of conducting research with a waiver of consent. And certainly, if using a waiver of consent wasn't possible, that would really hinder this research that's so important. So, as far as I'm aware, I don't think GDPR has had any impact on being able to do the trial with a waiver of consent. But in terms of the opt-out approach, I don't know whether anything will change there.
Okay, thank you very much. Lawrence is saying that he thinks it's a very impressive trial, so you may want to hear about that. And he was wondering overall, how did the participants react after they'd been told about their involvement in the trial?
Nice question. So the reactions were predominantly positive. And obviously these are patients that have survived a cardiac arrest against the odds, and their reactions were really positive towards the ambulance service and the hospital staff that saved their life. And in general, they were really happy to be followed up and just help in any way that they could if they thought it would help future patients. So definitely a lot of gratitude and this kind of sense of altruism as well, and feeling they wanted to give something back. I think the more tricky conversations were where a patient survived, but with a very poor neurological outcome. So some were in a severely disabled state after the cardiac arrest, and that obviously required an extremely sensitive approach when speaking to the relatives. And the relatives were almost going through a grief reaction. So we just had to time that approach very carefully and with the support of the hospital staff. But even in those situations, we felt that the relatives understood the need for the trial. Predominantly positive.
And did you feel that you learned any particular lessons from that process? Is there anything you would do differently again? Or would you replicate the consent process you used?
I think, we definitely learned a lot throughout the trial, and we had to take a lot of the situations on a very case-by-case basis, because obviously the recovery of patients could be so different, and the particular family situation. Where any cases were particularly challenging, we had the support of the team here and the chief investigator. We had a clinical ethicist who we could ask for advice. So I'd just say it's really important to not not rush that decision making. It's important to obviously inform the patient or the relative as soon as possible. But if it's a challenging situation, maybe just take a step back and get some advice from various people as to how to best make that approach.
And thank you. And we've got a couple of questions asking about the use of the research paramedics for the consent process. So someone is asking about why you chose the research paramedics, and then were there any problems or issues with it being those particular individuals that are taking consent?
So yeah, that's a good question. So we chose the research paramedics because they were obviously heavily involved in the trial, and they were delivering the trial training. And I guess the alternative would have been to use hospital staff in order to make that approach. And throughout the trial, I definitely thought a lot about which would be better, whether it would be easier having hospital staff making that initial approach, because obviously they can track patients more easily and see how they're doing. But in hindsight, I definitely think having the research paramedics was a good way of doing it, because they knew the trial inside and out, and they're quite used to having difficult conversations with patients and relatives. And I think it was also easier in terms of training. So we only had 26 research paramedics on the trial who we had to train to take consent and have these conversations. Whereas if we were to do the same in hospitals, I can't think how many hundreds of people that we'd have to train in order to take consent for the trial.
Yes, that would be really
hopefully
tricky,
that answers the question.
Yeah, thank you. And we have another interesting question from Callum Kay about the paramedics in terms of the training, so to connect those two themes we were thinking about before. Did the ambulance service fund the face-to-face training, or I suppose any of the training really, or did you pay the paramedics to attend, or did they have to just do it as out of goodwill?
Yeah, good question. So yes, we did pay overtime for paramedics to come in and do the trial training. And yes, sometimes the ambulance service is provided food as well for the training sessions. So I think all of that helped to encourage paramedics to attend.
So that must have been a substantial element to have attached to your funding, but it seems like it was quite appropriate.
Yeah.
And then about the paramedics as they were implementing the trial processes. So someone is asking, did you experience any issues with treatment packs being taken or used and patients not being registered on the system? So those sorts of logistical glitches.
Yes, definitely. We had a few cases where the research paramedics would found that a pack had been used, but they hadn't had a notification that a patient had been enrolled into the trial, so they hadn't been able to match up the two. But fortunately, we had a lot of fallback processes, which meant that we could easily link up a pack number to a particular case. So the research paramedics had various ways of tracking where drug packs had been signed on to ambulances, and they could see then which ambulance attended which job. And then speak to the crew to confirm that that pack was indeed used. Mm-hmm. And there was also so they could screen cardiac arrest calls on the audit systems to just check that every cardiac arrest that was attended by a trial paramedic had been registered on the database, or they would look into why that patient wasn't recruited into the trial.
Okay, thank you. And you obviously put a lot of effort into the advertising around the trial, thinking about the content and where to place things. Simon Finney is asking if you've got any thoughts about which advertising sites were the most successful in terms of increasing awareness of the study and the option of having the no study bracelet.
Yeah, so that's something we did actually collect some data on. So on the form that we used for people requesting a no study bracelet, we did ask them where they heard about the trial so that we could get a sense of where people were hearing about it. I think the data showed that the majority of people heard about the trial via news outlets and definitely on the television. Probably about 70%, something like that, heard about it through the news. And then there were other ways they found out, such as through GP surgeries, some from Facebook. Probably about 30% were through word of mouth, so someone else had heard about the trial and then they were talking about it. But this is something that we're going to look at the full data set and potentially write this up as a paper, because I think it's quite interesting.
Yes, I think that would be. Thank you. We've come to the end of the questions that have come up in the chat box. Charlotte, is there anything that you would like to add to any areas of the presentation that you think would be worth exploring a bit further, or do you feel you've covered everything?
I know I covered a lot during the presentation, and so just to say, if anyone had any further questions, I'd be happy to get in contact via email after the webinar, and that would be great.
Okay, that's lovely. Well, thank you very much. That was a nice pair to Addy's presentation, and I would recommend, if anybody wants to, that you see these two together, because I think they raise some interesting issues and inform each other nicely. And thank you very much. It was a really good presentation, very nice and clear. Thank you, Charlotte.
Thank you.
Thank you very much, everyone, for coming along, and we'll see you next month for the next seminar, which I think is being presented by Lucy Culliford from Bristol. Thank you.